Welcome to the Pelvic Ultrasound Lab video for the Medical College of Georgia. My name is Allie Falkenstrom and I'm a fourth-year medical student here at MCG. This video is intended to be an introduction to obstetrical and endovaginal ultrasound. The endovaginal ultrasound is performed using the endovaginal transducer, which is 7.5 to 10 megahertz. It is best to perform it with an empty bladder. It can provide a more detailed study than transabdominal because it shortens the distance between the transducer and the anatomy you are trying to visualize. However, keep in mind that because the transducer is of a higher frequency, it has limited penetration. Endovaginal ultrasound can be used to evaluate the ovaries or uterus when suspecting an ectopic pregnancy, or to look for pathologies such as ovarian cysts or uterine fibroids. It is also often used during the first trimester of pregnancy to document the presence of an intrauterine pregnancy. Contraindications for this procedure include patient refusal, intact hymen, narrow vaginal canal either due to a congenital or acquired condition, and the lack of patient tolerance. Before beginning the exam, you must first prepare the transducer. You want to be careful to not have air bubbles in front of the transducer face, so you need to put a small amount of gel inside the transducer sheath and then pull the sheath over the transducer face all the way down to the handle. The patient should be in the supine lithotomy position with their feet in the stirrups. For the longitudinal view, the transducer marker needs to be facing the ceiling or towards the anterior aspect of the patient. After inserting the probe, you will see a gray, homogeneous structure in the center of the screen, which is the uterine myometrium, as shown in the slide ultrasound image. The hyperechoic white line running laterally across the screen is the endometrium, or the endometrial stripe, which will vary in thickness due to the patient's age and according to their menstrual cycle. It is important to make sure you understand orientation when you begin an endovaginal ultrasound. Remember, this image is in the longitudinal view. When using this orientation, the top of your screen is inferior and the bottom of the screen is superior. The left side of the screen is anterior and the right side is posterior. Scanning throughout the longitudinal uterus can be seen in the following clip. After finding the uterus, you can now look for the ovaries. Keeping your thumb on top of the probe with the marker facing upwards, move your handle to the patient's left, which moves the face of the transducer to the patient's right and towards the location of the right adnexa. The ovary will look like an ovoid, homogeneous structure just lateral to the uterus, as shown in the slide ultrasound image. You can then move your handle to the patient's right, back through the uterus to point the face of the transducer towards the patient's left and to the location of the left adnexa. To examine the pelvis in the transverse view, you should rotate your hand 90 degrees counterclockwise so that your thumb and marker point towards the patient's right. You will now be seeing a cross-section of the uterus. In the transverse image, the top and the bottom of the screen are still inferior and superior respectively, as in the longitudinal image. However, this time the left side of the screen is the right side of the patient, and the right side of the screen is the left side of the patient. As you tilt your transducer handle towards the anterior aspect of the patient, you'll begin to see the more inferior portion of the uterus, which is the region of the cervix. As you tilt your transducer handle towards the posterior aspect of the patient, you will visualize the superior portion of the uterus towards the fundus. In this view, you can again scan to the left and to the right of the patient to visualize the adnexa. Scanning throughout the transverse uterus can be seen in the following clip.
Next, we will be looking at some introductory aspects of second and third trimester OB scanning. The curvilinear C6-2 transducer and the OB preset will be used for this exam. There is no patient preparation for this exam, and your patient will usually be supine. Some pregnant patients have difficulty lying on their back supine due to pressure of the fetus on their great vessels, which is termed supine hypotensive syndrome. This position can cause them to feel faint or nauseous and can be relieved by turning the patient on their left side. On subsequent slides, I will be discussing some very basic ultrasound scanning for a limited OB ultrasound exam. Documentation of fetal heart tones is the first step to the OB ultrasound exam at any gestational age. In the second and third trimesters, fetal heart rates range from 140 to 160 beats per minute. To document fetal heart tones with ultrasound, we will be using M mode, which is located just to the left of the 2D icon in the center of the Philips Spark console. First, identify the fetal heart in the chest of the fetus. Then initiate M mode and then move the cursor to the heart. You will see on the M mode display the valves of the heart opening and closing, which will appear as wavy lines. Once you freeze your image, select Calculations or Calc and choose the 2-beat peak-to-peak measurement. You will need to measure 2 beats as seen in the image in the next slide. Here is the M mode recording and image that you should acquire. This corresponds to the grading rubric item that asks you to correctly document fetal heart tones on the ultrasound image. You can see on the left side the calipers are placed on one peak and measured over to the second peak. This correlates to a fetal heart rate of 150 beats per minute as denoted with the yellow arrow. Notice that the M mode cursor or dotted line is placed through the chest and heart of the fetus to get this heart rate as seen on the right side of the image. Another aspect of the OB ultrasound exam that we will be scanning is fetal presentation. Fetal presentation varies throughout the course of the pregnancy, and we may need to document position prior to delivery. The fetus can be positioned vertex, which is the fetal head towards the mom's feet, or breech, which is the fetal head towards the mom's head, as shown in the slide diagram. To determine the fetal position, place the transducer in the longitudinal plane and identify the fetal head and body. Using your screen orientation, you can tell whether the head is superior or inferior on the mother. Here is an ultrasound clip showing scanning to document fetal presentation. Notice that the cervical spine is seen at the base of the skull, which clearly demonstrates that the fetal head is towards the inferior portion of the mom, which is called the vertex position. This is the image for fetal presentation that you should acquire that corresponds to correctly documents fetal presentational ultrasound image on the grading rubric. This is a longitudinal image, and you can see that the screen orientation has been labeled as well as the fetal head and spine. The fetal head is on the mom's inferior aspect, so we know that this fetus is in the vertex position. The location of the placenta is another aspect of OB ultrasound exam that we will cover in this lab. The placenta can implant along any aspect of the uterus. The location should be documented in order to rule out a placental previa, which is implantation of the placenta over all or part of the maternal cervix. Placental previa can lead to vaginal bleeding during the pregnancy and may dictate delivery by cesarean section. Other placental locations include anterior, posterior, and fundal, which are denoted in the slide diagram. Here is a short ultrasound scanning clip demonstrating the placental location in this patient. You can see that the placenta is located on the posterior wall of the uterus. This is the longitudinal image of the placenta that you should acquire. It corresponds to the grading rubric item, correctly documents placental location for ultrasound image. You can see that the placenta is positioned on the posterior wall of the uterus as shown with the yellow arrows. There is also an anechoic pocket of amniotic fluid labeled AF and a small part of the fetus seen in this image. The last aspect of the exam that we will address in lab is the documentation of amniotic fluid in the pregnancy. Amniotic fluid is crucial for growth and development of the fetus and should be documented on the ultrasound. Two objective methods of amniotic fluid measurement are the amniotic fluid index, or AFI, and the single deepest pocket method. We will be using the single deepest pocket method, which should normally range from 2 to 8 centimeters. To use this method, scan the whole uterus and identify the largest pocket of amniotic fluid that does not contain the fetus or the umbilical cord. Then measure the pocket from anterior to posterior. If the pocket is less than 2 centimeters, there is a decrease in fluid, or oligohydramnios. If the pocket is more than 8 centimeters, there is an increase in fluid, or polyhydramnios. This measurement can widely vary and should be repeated if oligohydramnios or polyhydramnios is suspected. To identify the single deepest pocket of amniotic fluid, you will need to scan around the entire uterus. Here is a short scanning clip identifying the single deepest pocket of fluid in this patient. Here is the last image that you should acquire. This image corresponds to the item on the grading rubric that says, correctly documents amniotic fluid, single deepest pocket on ultrasound image. You can see in this image we have measured the amniotic fluid pocket to be 5 centimeters, which is within the normal range. Also keep in mind that you will be scanning different OB patients, so your images will not look just like these in this video. The OB patients you scan may have different fetal positions, placental locations, and also may have variable heart rates and sizes of amniotic fluid pockets. Please contact me directly if you have questions prior to the lab. I'm looking forward to seeing you in lab.